Hello everyone, this is Health Economic Chapter 2. So welcome back. So in this chapter, we are going to discuss about the demand for healthcare services. And first, we are going to discuss a topic about whether the demand for healthcare follow the law of demand. Do we actually observe the downward sloping demand curve in reality? And then we will talk about the sensitivities of price elasticity for demand for healthcare. And then we will talk about how price of healthcare related to the health outcomes. Well, in the most basic principle microeconomics, I believe everyone here learns about how the law of demand works. So in general, the law of demand tells us when the price of the product decreases, the quantity demand of the product will increase. So for example, when we talk about the price of the lollipop, if it was set at $3, well, obviously there will be less people wants to buy the lollipop in the markets versus if the price of the lollipop is $1. And of course, the lower the price it is, the more of the lollipop will be demanded in the markets. So that's what we call the law of demand. Well, in the later sections of this chapter, we are going to talk about the price sensitivities of demands. Well, of course, we have learned from our principle microeconomics, there is nothing go against the law of demand. But we would like to actually think a little bit more in depth about the demand for healthcare services and also take a look at how different healthcare services has a different price sensitivities in the markets. So just recall from our previous principal courses, when we talk about a demand is price elastic, so that means consumers for these healthcare services are very, very sensitive to price change of this service. On the other hand, if the healthcare services, it's inelastic, so that means people who are in needs for those services are not very, very price sensitive, and they will not change the decisions whether they want to get those services according to the price. So the general question to ask is, are people sensitive to price of healthcare services? So there might be some demand that we observe in the markets, like the demand for a vaccine. So the vaccines in the market might actually vary in prices. However, I would say in general, people would like to actually take the vaccines in the flu seasons, regardless what the price is. So in this case, if the price actually changed by a lot, but the quantity demanded of the service vaccines, it's not changing by much. Well, in this case, the demand is what we call price inelastic. Well, on the other hand, I would say, well, most people have bought Band-Aids before. Well, obviously, whenever people need the Band-Aids, well, it's when they got into some minor injuries. So in this case, well, people might actually buy more of the Band-Aids when the price of Band-Aid actually decrease, or maybe the quantity demand of Band-Aids will actually reduce by a lot if the price of Band-Aids are very, very expensive. So in this case, the demand for Band-Aid might actually be very price elastic. But the thing is, if people always obey their doctors to follow what they tell you, well, the demand for any kinds of healthcare services will be extremely inelastic, because the fact is, well, the doctor tells you that you need those services. Well, hardly we will believe that we don't want to take those services. Just like any other economic studies, well, healthcare services, it's just like all the other services and products that we buy in some way. The demand for healthcare basically is an economic trade-off that balances the marginal cost of care against the marginal benefits of that care. Well, understanding or maybe visually illustrates the demands for healthcare services will help study the important consequences for designing of the good healthcare policy. So let's talk about a general problem that we face in the study of demand for healthcare services. Let's suppose we are trying to find out whether the people living in a city would like to get certain types of healthcare services at different prices, and we send out surveys to ask those people. We might actually get a result of the demand illustrated by the demand curve on the right-hand side diagram, DM. Well, this result actually reflecting, well, how much people are willing to pay and not actually dividing up them into a different group of people. Well, the problem in this case is, well, they might not actually be people who have the same condition to demand for the services. In general, the biases, it's created because there might be some people, or I would say people who in needs for those services, they might already getting the insurance package to pay off those expensive services. And on the other hand, there might be people who choose less generous insurance that are healthier and have a lower demand on those healthcare services. So in the case of this study, we might actually have the true demand for the healthcare services represented by the DT demand curve, where the price is high, we tend to underestimate the demand, and at the lower price, we might actually overestimate the demand for healthcare services. Well, the problem that we face is people generally choose the amounts of insurance they receive according to whether they are actually sick or maybe they're healthy. Of course, the people who are sick already, they will choose a more generous insurance. And indeed, partial of those services will be covered by insurance company. So they are more likely to demand those services at a high price. But on the other hand, well, since people who are healthy, usually they will not demand that much of a health insurance to pay off their health bills. So in this case, well, the demand for those lower price healthcare services should be a little bit lower than what's it's being captured in the survey. Well, because of the problems of biases, well, we are going to use an alternative way to illustrate the demand for healthcare services. So the next best alternative is what we call the randomized experiment. It's an experiment that assigns treatments randomly to different groups of study participants. So basically in this study, we are going to divide the populations into two groups, including what we call the control groups, which is randomly chosen and receive either no treatments. Another group is what we call the placebo treatments group. Usually they are the groups who it's given the treatments and they would have received it if not enrolled in the trials. Such study will provide a most persuasive evidence on questions of causality in the social science and medicines. So obviously this is a much better experiment that illustrates the demands for healthcare services or any kinds of healthcare related products. In this chapter, we mainly going to observe the results from two randomized experiments in the United States. Well, one is the Rent Health Insurance Experiment, and the other one is the Oregon's Medicaid Experiment. So the Rent study actually conducted between 1974 and 1982. And the Oregon Medicaid Experiment was conducted in the year of 2008. Well, let's take a look at what's the difference between the two experiments here. Well, for the Rent study, Rent researchers actually randomly assigned 2,000 families from 6 American cities to one of several different health insurance plans for several years. And this plans varies on generosities of coverage. In particular, the plan has a different co-payment rates. So the co-payment rate for the insurance plan is a fraction of the medical bills for which the patient is responsible. So in this case, the 2,000 families in the United States in different cities was assigned to maybe a family that sent to 0 co-payments, or maybe 25% co-payment they have to pay, or 50% of co-payments they have to pay, or maybe even 95%. So the assigns of these families are totally random so that we can actually see how this group will behaving when given a different generosity of the insurance package. In the Oregon Medicaid experiments, they actually took a different route. They did not assign participants to different insurance plan. Instead, they compared two groups of low-income adults that live in Oregon. So people who won the 2008 lottery to receive the opportunity to apply for the public's health insurance coverage through Medicaid, and another group of adults or lottery entrants who did not win the lottery and were not given a chance to apply for the Medicaid. So in effect, this lottery randomly assigned insurance coverage to a subset of winners. And the lottery winners tend to face a lower out-of-pocket price for Medicare. So in this case, again, we are trying to observe people with different healthcare package and how much money they have to pay out of pockets in order to observe the behaviors of these different populations assigned to the different insurance package group. So in general, the results that we got from both experiments are very encouraging because for all the healthcare services that we study in these two experiments are all illustrating that the demand for healthcare services are downward sloping. So regardless, we are talking about heart surgeries or maybe a flu shot or maybe vaccinations, or maybe even though when we talk about a medical prescriptions, well, they all follows the law of demands, which means when price change, actually it affects the demand for healthcare services or maybe healthcare in general negatively. So we do see this downward sloping demand curve from these two experiments. So we can talk about several different healthcare services in these two experiments, but I would say the most important things that we care is basically are the services that we use the most. Well, one of the most common types of healthcare services is the outpatient care. So the outpatient care basically are the medical care or maybe health services that we get that does not involve any overnight hospital stays. So that means for any everyday doctor visits, let's say if you run into a problem of runny nose, if you twist your ankles from basketball games, or maybe you broke your legs, that does not require overnight stays in the hospital, well, obviously those are what we call the outpatient care. On the other hand, the inpatient care is also one of the major kinds that we usually see. So basically, it's the medical care that require overnight stays, such as when we are proceeding heart surgeries, or maybe we are trying to proceed more serious surgeries in the hospital that requires to stay overnight and keep monitoring by the doctors, or maybe in most cases, if you get your head in a collisions, doctor will advise you to stay in a hospital for all the checkup. And also there are some emergency services that we sometimes might experience in our life, which is the ER care. So the emergency care or the emergency room care, it's basically the the health services that we actually got into for whatever that the conditions happen in our life, such as when we have a heart attack or when we have a stroke, that can that we are immediately sent in by the ambulance and such. So if we are going to compare the results in the RAND experiments, so obviously we can actually take a look at some of the outpatient care and how is it going to reflect the result of downward sloping demand curve for these services. So the table below basically illustrates the data studied by Kaylors in 1988. So you can actually see from the numbers. So let's take a look at the left-hand columns, which is the plan. So the plan actually illustrates what's the copayments assigned for the random experiments in the RAND study. So the free, basically, it's a zero copayment. 25%, it's the 25% the patient has to pay for the same service. And then 50%, it's 50% copayment the patient has to pay. And 95 is the least generous insurance plan, which is 95% the patient has to pay. So obviously, you can actually see the average number of annual episodes by conditions. The total episode, actually, it's around 2.99 in totals, comparing to if the patient has to pay 95% of the copayments, the average annual episode will be 1.9. So it's about on average, one episode less than the average when people is not required to pay anything out of pockets. You can also take a look at the chronic health conditions, right? So even though we assume people with chronic diseases, they might actually still in need of those healthcare services, but given people have this zero copayment plans, they will on average to have this 0.7 episodes by conditions annually, comparing to if people is given a 95% copayment health insurance plan, they will only visit the doctor 0.46 times in the year. So obviously, all this number actually illustrates as the level of copayment decrease, there will be more and more of these health services to be demanded. Also, we actually take a look at the data collected by the Oregon Medicaid study. We also found a very, very similar results, which is the lottery winners, which the people who got this more generous Medicaid healthcare package actually use more of the outpatient visits comparing to the lottery losers, which is the people who don't have a chance to apply for the generous Medicaid programs. So in this case, well, both the RAND study and the Oregon Medicaid studies actually find a downward sloping demand for outpatient care. Well, in the case of inpatient care, well, in the RAND study, we actually still find this downward sloping demand for inpatient care. Comparing different health insurance package, when people it's given zero copayment, they will have on average 0.133 times visits per year. Comparing to if people have this less generous or the least generous 95% copayment they have to pay out of pockets, they will only have 0.098 times visits per year. Well, the downward sloping behavior is still observed from this RAND study. However, the magnitudes of these changes, it's a lot less comparing to what we found in the outpatient care services. Also, in the study of the Oregon Medicaid study, we still find some marginal difference between the usage rates of the lottery winners and lottery losers. However, it does not make a statistical significance impacts to the study. So this actually illustrates a very important information, because obviously our logical sense tells us people who usually use this inpatient cares are the people who are in more serious or severe conditions. Maybe they have this broken leg that they have to do a surgery, or maybe they have this long-term problem, a chronic disease that they have to require these surgeries for several days stay in the hospital. So people who need those services might actually be a little bit less price sensitive. So in the case of this inpatient care, we found that demand is still downward sloping, but in general are less elastic than the demand for outpatient care. Well, if this applied to our logic's demand for a more severe or maybe more emergencies types of services will be less elastic, or will be less elastic. That means, well, if we are going to take a look at the services for emergency room care, obviously we will find something that's more in line to this result. So in the case of the emergency rooms service, we still find there are some level of difference comparing the people in different healthcare package in the RAND study, but it does not make all the numbers to be statistically significant. So only when we are comparing the people who need to pay 25% of co-payments and the 95% co-payments, we found that there are still some level of statistically significancies on the impact on this co-payment package. So 25% co-payments, about 19% probability people will use the ER services, comparing to people who has 95% of package co-payments. They have about 15% probability to get into this emergency rooms service. And obviously this emergency room services or emergency room care might not directly related to the price of the services. And indeed, sometimes if people who got into this accidents may be totally random. So it's not necessary that they are given a lower price. They might actually try to use more of these ER services. And in the Oregon Medicaid study, there is also no significant difference in the ER services for the lottery winners versus the lottery losers. So even for emergency room care, still the most urgent types of services that we use in our life, still we found some very, very encouraging results that suggesting the healthcare services, the demand for healthcare services is still directly related to the price, or maybe in this case, the co-payment plans of the service. So we have seen some evidence that illustrate the demand for healthcare services. It's downward sloping with different sorts of cares, of course. People actually trade off their health against other goals in almost every conceivable situation. But consider how pediatric care, which is the care for infants and children, and also it's typically types of care that pay for by parents out of pockets. Despite all the evidence we have seen for the downward sloping demand, it's very difficult for us to imagine that the parents would skip on care for the children because of price. However, when we take a look at this data from RAND study, we might actually find that, well, the parents are also very price sensitive to this kind of services with respect to the healthcare for their children. Families on free plans will significantly more likely to have these immunizations or preventative care for the infants, toddlers, or young children, which is aged from 0 to 6, than family with positive co-payment rates. So people who don't have to pay out of pockets will bring their kids to have this kind of preventative services, comparing to family who are facing this co-payments, regardless what how much the co-payment is. Still, on average, they are actually getting less of these services for their children because of the out-of-pocket payments. Well, even though we don't see evidence applied to people who are from age of 7 to 16, but this also illustrates how the different healthcare services also having this downward sloping demand behaviors. Well, not only the pediatric care illustrates the demands, it's downward sloping, but also in the case of mental health care or the dental care, we also have found similar results. So in the case of mental health expenditures, you can actually see how the mean expenses on these services changes through different plans. So people with zero co-payments on mental health expenditures in general will spend $42.2 on the services, versus if the person who need to pay 95% out of pockets, they will on average only spend $18.1. So the percentage of free plans that used by different co-payment plans are 25%. If you have to pay 25% co-payment versus the free plans, people tend to only attend 67% of these services, and people who require to pay 50% on the co-payments, they will only use 33% of what the free co-payments group will be using, and the 95% will use about 43% of the total 100%, which is the free co-payment plans populations will be used. And the dental care is also basically the same evidence here. So people who assign to this free co-payment plans, on average, will spend $317 average expenditures, versus 95% co-payments. The low-income groups will pay $216 on those services, and for the high-income groups, if that family or maybe that group of populations is given a free plans, zero co-payments, they will on average spend $339 on the services, versus the 95% co-payment plans individuals, they will use about 234 average expenditures on those healthcare dental service. Prescription drugs also have the same types of results that we got. When we look at the data from RAND study, for people who in the free plans, the 0% co-payment plans, there are about 0.17 of antibiotic per person will be used in the Ferrell's conditions, and about 0.08 of the antibiotic per person will be used under the same conditions. And also in the different conditions, in the bacterial conditions, the free plants will have about 0.47 number of the antibiotics assigned for that persons, comparing to people who have to pay a co-payments, they will only use about 0.24 of the antibiotics per person. So all these results are statistically significant, and also all this result it's suggesting or illustrating the demands are downward sloping. Well, other than the randomized experiments, we also find some other evidence from a non-randomized experiment. So the setup is the following. So let's take a case in the United States. Citizens in the United States turning 65 or older, they can they are eligible to apply for health insurance through Medicare. So basically, it's a health insurance package that's offered by the government. So we will expect if the demand for healthcare is downward sloping, there should be a jump in the healthcare services for people who turns into the age of 65. So we are assuming if there are some people out there with no insurance before the age of 65, so before they retired, they are not covered by any source of insurance. And indeed, they would like to actually get some of the procedures done, or maybe some kind of medical services for their life. I would actually, it's pretty logical to expect those people to wait until they got into the Medicare programs and having this insurance package to cover for those expensive bills. So there should be a gap between the age of 64 and 65, or maybe there should be a very, very huge jump of those healthcare services for age of in between those 2 years. And this discontinuity is basically what we call discontinuity study. There is a discontinuity in health insurance at age of 65, and some evidence it's been found by CART 2009. So in CART studies, there are two main things were found. So number one, there are extremely high unplanned emergency department admissions follow this linear trend around the age of 65. So that means there are some people who are about turning to age of 64. We don't actually see a lot of emergency admissions to the hospital, but right after age of 65, they immediately bring themselves into the hospital to get those healthcare services that they require or they need. Other hospital admissions also jump at the age of 65 for most of the patients in the study. So the evidence here actually suggesting there is a discontinuity in medical usage at same points of discontinuity in the Medicare coverage. And this is a future evidence that demand for healthcare is sensitive to price. So this kinds of study actually help us to understand not only people with income will care about their health and trying to determine what's the level of healthcare services they would like to use, even though people getting into the age of 65 or 64 with the conditions they have, people will still consider, well, how much they have to give up in life, right? So the marginal cost to get those services comparing to the marginal benefits of receiving those services at the cost. So in general, the demand for different types of healthcare services are downward sloping, and this evidence actually helps the governments to design the policy that most likely will benefits the publics in the country. Well, but another problem that we are facing is, well, how sensitive those services are to the consumers. So in the study of demand, we actually have this tool to talk about the price sensitivities of different products. So in the study of Killer, 1988, Dr. Killers actually found that the dental cares and outpatient cares actually have different price sensitivities. So in this case, obviously, we have discussed the price sensitivity might actually different comparing to services that has more emergency conditions or maybe more severe conditions of the patients to other types of services that it's in less urgencies. In the study of price sensitivities, of course, we cannot actually compare when the same price changes for two services. Let's say the price of heart surgery actually drop in price of $10 comparing to the price of flu shots actually dropped by at exactly the same amounts, $10. The quantity demands of heart surgeries or maybe a flu shot in this case might actually be very, very different, and we cannot compare those. So we have to find one very convenient tool to make this unit less measures in the price sensitivities of the healthcare service. One very common tools that we use is what we call the art elasticities. So art elasticity equation is represented by the following equations here. So usually we will actually calculate the percentage change of quantity demands of the service divided by the percentage change of price of those services. And we have a separate video that helps you to study by using these equations to calculate the healthcare services in reality. Well, here let's take a look at some of the services or maybe products that we buy in the regular day life. So let's take a look at the elasticity of demand for fresh tomatoes, which is negative 4.6. So that means, well, the price of tomatoes actually affects a lot on the quantity demands of potatoes. So people who buying fresh tomatoes are relatively price sensitive, so they do care about the price of the tomatoes in the markets. Well, this is one reason to explain this elasticity of tomatoes is substitute, because given so many choices out there in the markets, obviously people seeing a higher price of tomatoes, they might actually shift their consumptions or expenditures on other types of goods or foods in the market. Restaurant meals are about negative 2.3. Movie, on the other hand, it's relatively inelastic. It's about negative 0.9. Coffee is very, very inelastic. It's about negative 0.25. Well, obviously, people who drink coffee, they are very, very price inelastic. And salt is about negative 0.1. And all the inpatient cares, the outpatient care, the dental cares, and other types of cares, it's standing around between negative 0.14 to negative 0.22. So we define the goods, it's elastic or price elastic when the elasticity of demand is between negative 1s to infinity negative number. So negative infinities. And we also defined the good is price inelastic. So that means, well, people are not very price sensitive to those goods when the price elasticity of demand is falling between 0 to negative 1. Well, the sign of this elasticity of demand is always negative because of the law of demand. So when the price of the one good is increasing, well, obviously people will only buy less of those goods. So this negative sign reflects the law of demands. So there are overwhelming evidence that suggesting the demand for healthcare is downward sloping. Sometimes the elasticity of demand might vary, but indeed, people do think about whether to get access to those healthcare services depends on the cost of those services. So that also suggesting people actually sometimes do skip on the healthcare services. So the next big question to ask is, how does it impact on the healthcare services, and also does the price of healthcare actually have impact on health outcomes? I think the simplest way to compare health of different groups is with mortality rates. So the Oregon Medicaid experiments actually tracked participants' survival rates, and they actually failed to find any significant difference between the survivals of Medicaid lottery winners and lottery losers in the first year after the lotteries. By contrast, a different study of Medicaid programs in the US does find that the insurance coverage reduced mortalities, but somehow those are the healthcare insurance to the populations of poor children in the US. So that means people are actually being affected based on the cost they have to pay for the healthcare services depends on their own conditions. In the RAND study, on the other hand, we actually find that there is no statistically significant difference between treatment groups. So that means regardless which co-payment groups you enter, you still have the same survival rates in the study. So the risk of dying for all participants is near identical under the free plans or under the co-payment plans. However, there are some results in the study actually suggesting the high-risk people on the free plans, they were 10% less likely to die than the high-risk participants on the cost-sharing plan. So that means people who are already sick in the free plans, they will be more likely to survive comparing to the sick people with more conditions in the case of cost-sharing plans. So that's evidence that we can only get from this study. So yes, in general, there might be some people it's being affected, depends on what's the cost that they have to pay for those services. But in general, we still find no strong evidence comparing to the whole populations. Well, in the Oregon Medicaid, again, we found no evidence suggesting the lottery winners and losers has any statistically significant difference between different groups. So does the price of healthcare affecting the health? So let's find out if we can actually track down some more evidence. So in both the RAND study and the Oregon's Medicaid experiments, it tracked down the mortality rates and failed to find any significant results between the control group and the treatment group. So in general, there is no health difference between people on the free plans versus the cost-sharing plan. Out of many health services that people get access under those two programs, obviously the RAND study suggesting the free plans people and also the co-payments plans people have almost identical health outcomes. So regardless whether you have to pay a co-payment or maybe you have a free plans, no out-of-pocket payments plan, the health outcome for individuals in those studies are basically identical. There's no statistically significance. So with a free plan does not make people healthier. Well, in the case of the Oregon Medicaid experiment study, well, we actually have a survey report, which is a self-report by the lottery winners. In general, the lottery winners actually reporting they have overall better health. There are more healthy days in their life, and also there are lower rates of depressions. So does it suggest that people with the Medicaids, right, government-backed insurance programs, it's better than people who don't have this insurance package? There is a discrepancy with the RAND study comparing to the Oregon Medicaid study. First of all, the Medicaid study actually studied very, very low incomes individuals, adults in the United States, versus the RAND study actually studied a much broader across sections income family in the US. So the people who are in the Medicaid study might be just because that they have this very, very low income status or maybe conditions, just having the government's insurance package might actually make them a little bit more secure, or maybe having lower out-of-pocket payments when they get sick, or maybe even just simply because they think that they have this advantage over other people with this insurance package, so it makes them a little bit happier. So there might be some discrepancy between the two studies here, but in general, we still hardly can find true evidence suggesting people are in general healthier with a health insurance package comparing to people who have a less generous or maybe even no insurance package at all. So there are a few conclusions we found in this chapter. First of all, the demand curve for healthcare services are in generally downward sloping. So we have already illustrated several evidence in different healthcare services. People do care about the price of those services, and the quantity of care demand is actually sensitive to price. It might not be as sensitive to other types of goods that we buy every day, like the computer games, the iPhones, or maybe your textbooks. But in general, still, we found that the healthcare services still follow the law of demand. Also, we found evidence to suggest the price of healthcare does not seem to relate to one's health outcome. So lower price of the healthcare does not actually make someone healthier, except that we found the price of healthcare actually affects only the most vulnerable segments of the populations, such as people with low income and people with high blood pressures or maybe other types of medical conditions, because those are the people who will be more likely to get access to those services. As the price of those healthcare services actually reduced, obviously the access of those services will be easier and helps preventing those people to get into even worse situations. And also the evidence in the Oregon Medicaid experiments also suggesting people with lower incomes have this Medicaid insurance package. They are in general better, or maybe at least it's a self-report, so they in generally feel themselves living in a better environment, or maybe feeling more happy to have a lower chance to get depressed. So all this evidence actually give us very important insight to form our future policy and also think about how the the health insurance should be formed in the future. So that's all we have for this chapters, and please try to work on the assignments on your own first and give suggestions to your colleagues or maybe to your cohorts for any things that you have, questions that you have. Please contact either me or maybe try to make the post on chapter 1's forum so that you guys can discuss online together. Thank you.